Peter.
Okay, if you give me a thumbs up or something when you want me to. Okay, thank you everybody for attending the convention. I'm delighted to open this with a presentation to look at some of the new insights in ITP. In particular, I'm going to talk about the new guidelines which came out at the end of last year, the International Consensus document and the American Society of Hematology document. And I shall cover some of the thinking behind the newer treatments for these. Now, this is my conflicts of interest. I won't pause on this for too long, but you can see I've been involved with many of the companies that have supported the association over the years. And what I'm going to start with is just a brief discussion of the classic treatment options. Corticosteroids, which have been around since 1950, good response rates with initial treatment, but sustained in between 10–30% at most. We have intravenous immunoglobulin, which many will be aware of, which has been available since the late 70s, early 80s, and is frequently used now, mainly as a rescue treatment, as an early option for rapid recovery. Splenectomy hit its 100th anniversary in 2016, but is now declining, and I'll come back and talk about that. A good response rate initially, which is always how we used to describe it, but of course we have to remember that a significant proportion don't respond and a similar number relapse. So maybe only 50 to 60% will have a long-term response for that, and it's the 40% that you may see problems in. And then of course we have those with refractory ITP, of whom it's at least a third, and we have a whole mix of immune suppressive therapies, or did initially, none of which is particularly evidence-based. And the reason for putting this up is just to remind you that many people, many older clinicians were trained with this as the treatment pathway for ITP, and many still follow it. Many will still look at splenectomy as an early option. Many will use the immune suppressive agents and will forget that they're now much newer options. And there are specialists who understand ITP who, in a lot of patients, should be running treatment. But I thought it worth just running through that to start with. And it was really on the basis of that that in the late 90s, early 2000s, that we produced the very initial guidelines in ITP, the consensus guidelines, which at that stage were the British Society of Hematology Committee on Standards in Hematology and ASH. We updated those in 2010. Both the international document now had many more authors from many of the countries in the world, and ASH was still mainly an ASH guideline. But of course, it's worth remembering that in 2010, when the 910, when these came out, rituximab was just being used, and the thrombopoietins had probably just about got a license, but we had no real understanding of their usage. The third document I put up is one that's probably less known to patients, but this was standardizing the terminology in ITP so that we had the names being consistent, we had the description of responses being consistent, so that publications could be compared with each other rather than using authors' own ideas of what responses may be. And that's guided a lot of the publications that we've been able to compare for our recent review of this. Now, why did we need to update? Well, I think there are a whole lot of reasons. The older guidelines, which are now over 10 years old, had vague, what we call vague, unrealistic goals. We wanted to normalize platelet counts. We wanted to treat as aggressively as possible. And there have been major changes in both the management of ITP and in our thinking about it. We're moving away from developing arbitrary platelet targets to hit. We're looking at the patient much more as a person rather than a disease that we're treating. So it was quite clear that the 2010 International Consensus report does not reflect current practice now. And so we asked ourselves in considering this, what was the most important consideration? What should guide everything that we do? And the answer to that is simple: quality of life. What is the quality of life for the patient? And I'll come back to this time and again over the next 20 minutes or so. So it's the quality of life, not the platelet count. You want to stop bleeding, but you're not striving to get a count that looks good for the sake of it. So what's changed over the last 10 years, coming back to that point? We realize that patients don't need a normal count. You can stop bleeding with a count of 20 or 30. You don't need a count of 150. Treatment, we know, often makes patients feel worse. We know that 20% of patients having received steroids will never take them again. We know that nearly a half don't want to take them unless there is no other choice. So we wanted a more hands-off approach with, again, focus on quality of life. What's important to the patient, not what's important to the doctor, and not makes us feel good by seeing the count's normal. And medics are often as bad as that in pushing the fact that, oh, your count's normal, that's great, or it's gone up 20 since last week, despite the fact that last week the count was perfectly normal for stopping bleeding. So we have to involve patients in the decisions as to why we're doing what we're doing, and convince everybody to forget about the absolute numbers of platelet counts. So that being done, we decided to update the International Consensus Report. So we expanded this to a lot more experts from around the world. In fact, we've got someone from everywhere, except unfortunately not South America. But we do have people who reflect what's happening there. And we discussed it with the American Society of Hematology, whether they wanted to come in with us, but they were already deciding to work on their own document. And you'll see there are a number of authors who are common to both. So we're not going to make recommendations that contradict each other. But these two documents came out in November of last year. And so the key themes, what we're aiming for in all our discussions: we wanted to treat the patient as an individual. We want to engage the patient in discussion, or in terms of children, we want to engage their parents and the child themselves that they're old enough to understand. Of course, we want to prevent serious bleeding, but we wanted to do that with minimal toxicity. We're aiming for counts of no more than 20 to 30, if that fits in with the patient's lifestyle. And that, of course, optimizes quality of life as well. And we know that patients with lower counts have severe morbidity and toxicity, both from bleeding and from the psychological problems. And you can swap that with significant toxicity by giving too much treatment to get a count higher than it needs to be. So we're balancing all those options. So what are the key themes of the treatment? We want to drastically reduce the time on steroids to no more than 6 weeks. And if steroids are continued at an extremely low dose that's lower than we know causes side effects. We want to use the thrombopoietin receptor agonists, that's eltrombopag and imiplastin, earlier in the course of their disease. We want to aim to taper and stop the thrombopoietins in selected patients. We know that 20 to 30% may have a long-term response off treatment, and we want to find those. And we want to avoid toxic treatments, particularly the immunosuppressive treatments that we know cause so many issues, and particularly cause issues in patients who failed splenectomy. And in particular, and I put it separately at the bottom, we want to make sure that people don't have a splenectomy unless they've tried a thrombopoietin and failed. So looking at the thrombopoietins, as I said, in the 2010 guidelines, they were just coming on available to patients. In the last 10 years, we know that they've transformed treatments, but we also know that we still don't know entirely how to use them properly. But we know by using them earlier, there's a good response. We know that we don't have to give them lifelong, which we initially thought we'd have to. We know that we can stop them and maintain the response. So in the new consensus document, we were looking at a whole range of treatments, both in adults, in children, in pregnancy, in an acute situation. And so, and a second line, we wanted to use all of those areas for recommendations, which, as you can see from the 2010 document, which has got the circles, is the comparison of how we expanded what we're doing. The ASH document was looking at, was more focused than our document. They weren't looking at some of the other situations in quite as much detail, and I just marked on this slide the comparisons of what the recommendations are. So what we've tried to do in the consensus report is to be a lot more inclusive in looking at the whole panoply of ITP. So what were the main points from the consensus? I've touched on some of these already. The treatment has to be patient specific. Steroids are first line, but we're restricting the usage. Steroids are cheap, they're oral, you don't have to be admitted, they work quickly, and are an important usage early on, provided they're not abused. We divided further treatment into whether it was medical or surgical. Splenectomy is no longer called second-line treatment. We don't have a second-line treatment. We recommend it as a separate line of treatment, but do recommend the predictive studies. We're looking at indium label, that's radioactive label platelets, to see whether destroyed, to see if splenectomy is likely to work. And if it doesn't, then we know that we can avoid that as a possibility. The early usage of the thrombopoietins, the FDA, the Federal Drug Administration in the States now accepts that as a proper use. We also want to look at the unmet need in patients who can't tolerate the thrombopoietins, of which there are a number, and we now have fostamatinib, a new drug that was licensed last year. And there are a number of newer experimental treatments coming through that should only be used in the context of a clinical trial, so we can assess how they're being used, what their effects are, whether they can be discarded or incorporated into bigger studies. So what's new in looking at the whole aspects of the report? In diagnosis, there's very little. We've expanded the differential diagnosis, i.e. those are the things that cause secondary ITP, in particular things like hepatitis B, C, some of the other infections. We decided that bone marrow is not necessary in a typical presentation. It's only if the patient doesn't respond or there's something else wrong with their blood. It's not just a purely low platelet count, is bone marrow needed. And then there are a variety of other studies that should be done. In adults, we've assessed the thrombopoietin data. We've looked at fostamatinib and, as I said, splenectomy only after the thrombopoietins have been tried. In pregnancy, looking at drugs like cyclosporin, the thrombopoietins, and a drug called recombinant thrombopoietin, which isn't available in the West. This is a Chinese drug that looks quite effective and may become available in the future. In pediatrics, of which you'll have a very good talk later in the convention from John Granger, looking at the more aggressive use of newly diagnosed children, and in particular the thrombopoietins. And as I said, we have a new section on quality of life, and indeed we had a representative from the American Patients Association rather than the British one this year. We did in 2010 have an input from the Support Association, but we used someone from the States this year to emphasize the importance of quality of life and patient input. So overviews of treatment. Initial treatments are with steroids, plus or minus intravenous immunoglobulin and anti-D. Then we look at subsequent treatment. We don't talk about second line or third line, we talk about subsequent treatment. And we've split that into those with robust evidence, which are the thrombopoietins, eltrombopag, romiflostin, plus the new thrombopoietin, avatrombopag. Fostamatinib, which I've mentioned, which is just licensed, has a different way of action. It stops the destruction of platelets. And rituximab. Although rituximab hasn't got the same level of controlled trials, it's now been used for such a long period, we have a feel for what it can achieve in real life. And then there's those with less robust evidence, which are a lot of the old classic immune suppressive treatments that many of you will be familiar with. And then we've split off surgical treatments as an option for splenectomy, which again, we recommend isn't considered for at least 12 or even 24 months because of the issues where you may see spontaneous response or responses to other treatments. So just quickly going through as an example, say in the newly diagnosed patient, prednisone, maximum dose, although we say 1 milligram per kilogram, a maximum dose of around 80 milligrams for 2 weeks, maximum for 3. If the patients respond, you then taper the drug off, and by 6 to 8 weeks, you've stopped it completely. If the platelet count drops during that period, you don't go back on it again, you look for something else. If there's no response within 2 weeks, you taper it and stop it. We know that if steroids don't work initially for a long period, they're not going to. And to continue with higher doses is going to cause nothing more than side effects. And then the use of intravenous immunoglobulin at that stage. The thrombopoetins and the rituximabs aren't considered initial therapies, except in rare situations, which I'll come to. They're further line treatment after failure of steroids. So to summarize steroids in 5 bullet points, they're used as first line. You give a short course. You may rescue a patient who's had a good response in the past or has come in having relapsed. You don't keep repeating the cycles, and you don't increase the dose when the platelet count drops. And this will minimize the side effects. And we know from our registry that the majority of side effects that patients with ITP have, apart from the bruising and bleeding, are the side effects of steroids. The anxiety, the stress, the poor sleep, the increased eating, weight gain, diabetes, hypertension, cataracts, all those sort of things that we know steroids are capable of causing. So when we go on to subsequent treatments, just to reiterate that point, we have medical, we have surgical, we have those with robust evidence, we have those with less robust evidence, and that's how we consider the treatment options. So the summary of the recommendations for further treatment: the thrombopoetin data has been updated to support our recommendations. We've added the new agent avatrombopag, which is a third thrombopoetin, and we've added fostamatinib, which I said works in a different way and has potential in patients who can't tolerate thrombopoetins or who relapse from them. Thrombopoetins can be used in patients who are splenectomized or non-splenectomized, but splenectomy is only recommended after failure of medical treatment and should be at least a year post-diagnosis. We know that you can switch the thrombopoetins, and if you don't respond to one, you may respond to the other. We know that there's efficacy over long term from what was called the EXTEND study in avatrombopag, and the rimiplostim study also shows counts are maintained for 2 years if necessary. But we also know that patients who have a good response, you can start tailoring the thrombopoetins at about 9, 12 months, and many patients, at least a third, will maintain a count. I said at the beginning, in the last slide, that we don't use thrombopoetins as an initial treatment, but they're often used in an emergency treatment. Patients who present with a relapsed disease or who may present with a lot of bleeding will be given steroids and intravenous immunoglobulin. In some of those, we may well give a thrombopoetin at that stage, because if they respond well, we can then tail it off. If they don't respond to initial treatment, you've already got a week to 2 weeks treatment with thrombopoetins on board to try and enhance that response. Then I won't talk any more about children, as John is covering that, but again, fostamatinib for those who fail thrombopoetins or are unable to receive or tolerate it. The ASH guidelines, I'm not going to go into those in detail just because of the time, but the ASH guidelines also limit the use of corticosteroids to a maximum of 6 weeks, irrespective of response. They also recommend the thrombopoetins as what they call a second line, and we just call further therapy. They recommend it for patients with ITP lasting greater than 3 months. That's what we call persistent disease. We would prefer to say if a patient hasn't responded to treatment, we then go on to the next rather than give it times, 3 months, 6 months, 12 months. It should be given dependent on the patient's need. And as we think, and the ASH guidelines reiterate that thrombopoetins are preferable to splenectomy and also probably to rituximab as well, delay splenectomy. They've also recommended the inclusion of patient-reported outcomes to ensure that the information gathered closely benefits what matters to the patients. and we must just reiterate how important we consider that to be. So what about subsequent treatment? You wait 12 to 24 months. Don't do splenectomy unless the thrombopoietins are being discontinued. It's always seemed rather strange to me that patients are given thrombopoietin, they respond, and then the spleen's taken out. Well, if they responded, why subject someone to what's a bit of major surgery? You continue on the thrombopoietin and then try and tail it off, and only then consider splenectomy if need be. Platelets should be above 50 pre-splenectomy, and that's debatable, but it certainly makes for a safer surgery. We also know, and I'm going to illustrate that in a minute, that increasing age associates with a higher relapse rate, and the use of predictive study, radioactive labeled platelets prior to surgery to look and see where platelets are being destroyed, because you don't want to take a spleen out if it's not responsible for destruction. This is some data from the UK ITP registry, which looks at the response post-splenectomy at 1 month, 6 months, and 12 months in patients younger than or older than 65. And what you see here is those older patients at 12 months, less than half have continued to have a response to splenectomy. This is data from 350 splenectomies that we've collected. The average age, the median age was 40 with a median follow-up of 8 years. We see here the median duration of response, which I put in bold, in patients over 65 was 0.8, which is less than a year. That's little more than 9 months. So that's major surgery, major disruptive surgery for a small response. And the more treatments patients have had, the less likely they are to have a good response. And what's also important is the complications. 12% of patients had infections post-surgery. Slightly more, 15% had some sort of thrombosis, either arterial or venous. Only 12 patients died, I say only. 1 was attributable to surgery. So we have to consider, splenectomy is not a straightforward and easy decision. It's something that has to be earned and has to be considered and has to be discussed with the patient before embarking on it. And this will be discussed by Vicky McDonald also later in the convention when she talks about some of the adult treatments and registry work. So the International Consensus Report, looking at adults, talk a little bit about pregnancy, which I mentioned earlier. We know that in the last 10 weeks of pregnancy, the thrombopoietins can almost certainly be safely given. It's not licensed, but certainly once the fetus has formed, the potential for any problems are significantly reduced. And the anecdotal numbers of patients who received it in pregnancy, there have been no problems so far. And so it can be considered in certain circumstances. I mentioned the issues of emergency treatment. In life-threatening bleeding, we may add thrombopoietin in to initial treatment with steroids, intravenous immunoglobulin, plus or minus platelet transfusions as well. And then there are a whole variety of treatments that we consider in patients who fail all the rest, combination therapies, new treatments, in particular clinical trials. But we also have to remember that supportive care can be useful. Drugs like tranexamic acid, which stop bleeding, maybe withdrawal treatment and just follow the patient. And if the patient doesn't have significant bleeding or has any at-risk activities, then that's often a better option to give a rest from treatment for a while. So looking at the two guidelines, they're very similar. Diagnosis, little changed. Thrombopoietins early on, second line rash, further treatment for the consensus document. Fostamatinib is considered for those who can't tolerate thrombopoietins. Splenectomy for both only after failure of therapy, and that has to be patient preference, and many patients don't want to do that now because they understand the implications. Earlier use of the thrombopoietins, limited exposure to steroids from both guidelines. Heavier treatment in pediatrics and quality of life must play a role in decision making. So for my final slide, what I would say is we have to look at the goals of treatment of what we've been trying to achieve with the guidelines and what we want to achieve in treating you, the patients. We want to individualize treatment to the patient and the phase of disease. there is not one pathway, not one approach that deals with everything. So you consider the patient and you discuss what your aims are. We want to prevent severe bleeding episodes while minimizing the toxicity of the treatment. And we have to remember that for the majority of patients, unless you are a professional footballer, a target platelet count of less than 20 to 30 is probably fine. If it's greater than 50, then you essentially have a normal hemostatic mechanism. You have a normal defense to bleeding. You don't need to go to normal levels. And finally, we should optimize the quality of life. Thank you very much for listening.